Hello, everyone, and thank you for tuning in to IFFGD's Research Award winner series, Where Are They Now? This program was designed not only to acknowledge this year as being IFFGD's 30th anniversary, but to also give us a chance to reconnect with some of our past Research Award winners. And today we have the pleasure of speaking with Dr. Tack, who was our 2013 IFFGD Research Award winner for Senior Investigator in Clinical Science. So thank you so much, Dr. Tack, for joining us today.
It's a pleasure and an honor, of course.
Yes. So can you actually tell us a little bit about yourself and where you're currently located, as well as some of your current research focus?
So I'm a gastroenterologist by training, and I trained at the university hospitals and the University of Leuven, which is an institution which has a strong tradition of studying motility with a heavy focus on esophageal motility disorders and actually focusing on achalasia and so on. And I joined the unit, well, I made a PhD there and joined the unit in 1994. And what the chairman at that time said is, we've done a lot of research on these type of patients, but we have done very little for the patients themselves. So you should establish like a good scientifically underpinned but high quality clinical activity, and I did that. So I created a motility clinic where we saw people with much more motility disorders, and we integrated research on them because there was a lot of lack of good evidence on how to treat these patients, how to approach them. And actually the clinic and the research has gone hand in hand. The unit grew, we published a lot, and I think it's the publications which were focused on the pathophysiology of functional disorders and exploring some new treatment approaches, and the heavy weight was on the stomach, on functional dyspepsia. I think this is what eventually made me eligible for the IFFGD award, because this was vested into clinical practice and based on improving clinical outcomes and treatment approaches and understanding patients' symptoms. And I think the road has continued after that. I got involved heavily with the Rome Foundation. I'm now the president of the Rome Foundation, which is a very visible segment of that type of care and science underneath it. And I'm also head of the division now in Leuven, which allows me to be even more involved in education for this type of care, manage to give this to the trainees who will become gastroenterologists in our country, and kind of perpetuate a kind of quality view and scientifically based view on this type of care.
Yeah, and you briefly touched on there how winning the IFFGD Research Award really propelled certain things into your field of research. But can you talk a little bit about how winning the IFFGD Award actually helped influence your career?
It has a couple of aspects. First, at the self level, this is an international award chosen by a panel of peers. So when you get chosen, it's a kind of recognition that what you have been doing has a level of relevance. So there is a clear sense of self-fulfillment with it, and that is already important, because that actually works motivationally. It helps you to continue doing what you have been doing. And it also puts you into the picture. You get an award ceremony where there's a lot of attendees, but also the award and who it is given to is well advertised, and it brings you into contact with other people. And over time, we've had international fellows passing by here, doing a clinical research stay for few months to 1 or 2 or 3 years. And I think it's the conglomerate of the research you have created, but also your exposure. And the IFFGD is part of that exposure that actually makes people decide that perhaps I should stop by in Leuven to see how they do it there. So I think all of that helps to create visibility for your unit and your team. And of course, if you get an international award, the hospital, the university picked that up. They put it on their website. They're proud to show it, but it also creates a level of acceptance of what you do and helps to get support within the hospital, within the unit, within the university for your activities. So, so this is a very important stepping stone. It is a step forward, and you, based on what you have done before, it's a type of recognition, but it's also a stepping stone to go on beyond that. And I think in my case, it worked really well in that sense.
That's an awesome backstory. And like you said, just gaining visibility with your research and getting that acknowledgement from your peers, it definitely is an advancement. It helps you advance other areas of your research and really grow that area. So, and speaking of some of your current topics, can you give us a little bit of a backstory about some of your current research focus? Like what are some of the topics that's going on in your lab today?
Well, you know, some people in the field, when you start to emerge and do some kind of activities, they notice you, and sometimes you get feedback. And one of the feedbacks I got at some point was from a famous investigator in the field who came to me, like a decade older than me. He said, "Jan, you're doing too much. You should focus on one thing." In my case, he said, "You should focus on dyspepsia because there's a lot to do there and it is not solved." I have to confess that this is not what I did. I continue to try and do a little bit of everything. So I have a program on esophageal disorders, starting with globus. We're studying pathophysiology of globus. We have a self-initiated interventional trial, treatment trial for globus. We do a lot on esophageal disease, reflux hypersensitivity. We have a study running looking at the mechanisms, and we have an interventional trial with an SSRI. We look at true reflux refractory to PPIs. We have an add-on prokinetic trial there. And then we're doing a lot on the more classical functional disorders. Functional dyspepsia, IBS are two heavy focuses. And we look at two aspects there. One is hypersensitivity, and we continue to study that and how neuromodulators will work and what is behind it. This is a real brain-gut disorder. It involves signals from the gut or from the stomach traveling through the brain, being too much amplified or too little suppressed, and causing inappropriate symptom burden and intensity and unpleasantness sensations. But we also heavily tap into the dietary approach. We are running a 6-food elimination trial in functional dyspepsia. We're running a FODMAP trial in functional dyspepsia where we see a real signal of efficacy in true dyspeptic symptoms. So it's not a spillover of IBS comorbid patients. It's really focused on the upper GI. There is a dietary component there. In IBS, we're looking at mechanisms of improving the reintroduction phase of the low FODMAP diet. We do that blinded with powders, and it gives a more objective readout. We have a very good response, actually. To the dietary intervention, it's more than 80% who respond to the low FODMAP diet in IBS patients in our trial. And then we want to find the mechanism. And for that, we're looking at microbiota, genetic predisposition, and sensitivity. And we're also looking at the food allergy component. So we're doing confocal laser endomicroscopy in the duodenum in functional dyspepsia and IBS. We have a histamine sensing catheter to measure quantitatively signs of food allergic reactivity, so mast cell activation. That is one big part. Second thing we embarked on is large-scale trials, because the population we study in our own trials and the populations I listed are tertiary care patients, the ones we see in our very advanced unit. The bulk of the patients is in primary care. So we just finished a trial, which I hope will be presented at DDW, comparing a app-based FODMAP lowering intervention with traditional primary care first-line medical therapy, a spasmolytic agent. We worked with 100 GPs who recruited 470 patients there. They randomized them, 235 medication, 235 the app, followed them for 6 months looked at genetics, microbiota, and the gist shows that there's a real benefit of the dietary approach, low interventional levels, self-administered at primary care level. The diet app was superior to the medical therapy. And again, together with primary care physicians, we're doing an epidemiological study finding the prevalence of gastroparesis. Primary care physicians send to us patients with a certain symptom profile. We actually do the emptying tests to unravel the prevalence of idiopathic gastroparesis at the epidemiological level. And we work with the Belgian Diabetes Patient Association to do a similar exercise to chart actually the prevalence of delayed emptying in type 1, type 2 diabetic patients. So we're not only focusing on primary care, trying to expand to other populations out there, and we made a successful GP program for epidemiology. So that's about what we're doing.
Yeah. And so we are learning a little bit more from those research studies and all those things that you are developing in your lab. We're learning so much about these GI conditions, but can you delve a little bit deeper into what you hope to really understand about these gastrointestinal disorders and how they impact adults and children?
Mm-hmm. I think there's a couple of things that we want to learn. First of all, we are systematically measuring symptom intensity, the impact on daily life, and how this is associated with comorbidity, anxiety, depression, somatization, trauma. This actually stems a little bit from a duality in the past where people were discussing, is it happening in the gut? The symptoms are bowel or stomach symptoms. Is it happening in the brain? Because we don't see anything if we look superficially in the GI tract. And some of these patients are more anxious. Trying to understand that. We're doing that not from a duality point of view. Not saying it's all in the mind or it's all in the gut. I think there is an interaction between both. And what I mainly adhere is that there's a vulnerability profile, which has to do with neurotransmitter functions that predispose you to develop anxiety, depression, as well as some of these disorders, because I think they are controlled by the neural system. And the vulnerability of the neural system may express itself in the periphery, if you get the hit there, or in the brain. If you get the first hit there, you may manifest first with anxiety, depression, or first with GI symptoms. But I think it's the same population that is susceptible to both. And if that is the view, there's a lot of research to do to unravel which neurotransmitter system is it. And it also helps to understand the comorbidity without being stigmatizing or being dogmatic, saying, you know, your bowels don't work because you're anxious, or you become depressed because you have so much GI symptoms. I think that is a refreshing view. And if this is the case, we need to chart which is the system. How can we understand it? If there's a susceptibility, what is the second hit that makes it happen right now? And I think that could be a GI infection or a bodily trauma or a psychological trauma. So I think you need a second hit to make it manifest. And third is, if you understand the system, we should be better at unraveling new therapeutic approaches. For that, I'm optimistic and pessimistic at the same time. I still do think that this is heterogeneous and that there's not a single answer to a single person. I think we're lumping groups of different patient settings and characteristics together. But if we can unravel one certain group, we can target these with more effectively with treatment A, and a second group maybe with treatment B. And I think this is where we need to go based on science, go for individualized therapy. Mm-hmm. And this is what we're working on. It requires systematically assessing patients' characteristics, doing intervention, see what works, what does not work. And it's not a short-term project, but it's a mid-term project. But I think we are gaining, really. The field has matured quite a lot compared to, let's say, where we were in the early 2000s.
Yeah, and kind of onto what you said there, patients experience things differently, and I mean, just the impacts of their disorder can impact them in different ways. So just better understanding how these how their disorder plays a role in their life and just how to tailor those treatment options based on the patient needs. I think that is a phenomenal way to an outlook for research and where we are to go. But like you said, still so much to learn. But I feel like that's the exciting part. What else can we learn about these disorders to better help and better assist patients living with GI disorders?
Yeah, and if you look at it from a kind of multi-dimensional approach, you're not dogmatically driven to one type of therapy. I mean, you could say, okay, gut-directed pharmacotherapy. Some people say this is where it has to be. Some people say, no, no, everybody needs a neuromodulator or hypnosis. I think we should explore many different aspects. So I think we should work on lifestyle. We should use dietary interventions. We should use peripherally and centrally acting pharmacological interventions. I think we need to work on the resilience of patients. We need to work with dietary interventions, probiotics, and functional foods. And I think each of these are valuable approaches, and none of them is mutually exclusive of the other. So for the complex patients, the more paths you can walk on, the better. And I think time will tell what is most efficacious and what is then the profile of the patient to primarily choose for that type of approach. And I think that is the richness of our field. We're not wed to one mechanism. We keep a broad view. In the past, it was motility, then you had sensitivity, then brain interactions played a role, the stress hormone system. Now we have the dietary approaches and the microbiota. I think the good clinician and the clinician scientist should be aware of all of these and try to use the full armamentarium if possible. That requires probably a larger scale setting, so a larger group, a larger hospital, but this can be done, and I think this is where we will advance.
Yeah, very valuable information there. So, in part of this, we all know that all research studies are very important, but what would you consider potentially being your most successful research study and why?
That's a difficult one, but I think probably the most resonating work has been on the pathophysiology of functional dyspepsia, showing that it is a bit heterogeneous, but then homing in onto two things. One is the idea that impaired accommodation, impaired storage, function of the stomach for a meal is a driver of many of the symptoms, not in every patient, but a substantial subset, especially with some worrying symptoms like loss of weight. And the second thing is the ongoing wave that maybe part of that is actually driven from the duodenum and low-grade inflammatory responses in the duodenum with activation of mast cells and eosinophils is a player. And we see some early evidence that this is therapeutically relevant. All treatments, we just published a paper in Gastro showing that PPIs actually work on this mechanism and generate symptom improvement just by stabilizing eosinophils, not by suppressing acid. But this is old therapy, which we understand a little bit better now why it may work. It doesn't offer any new things, but then if I see the mast cell pathway and the eosinophil pathway and some of the early biologicals, which are showing very robust symptom improvement, it shows that this is a right pathway to follow, and maybe we'll find easier working approaches to tap into these. Doesn't necessarily have to be a very expensive antibody that we inject, but the proof of principle is made, and we contributed a little bit because we showed that this is a group who have impaired mucosal integrity, eosinophil activation, and mast cell activation in the submucosa. We're working along that line. I think these are the two things that we contributed to this point.
Yeah, and just ways to really gain a better and broader understanding of how these GI disorders can impact the patients. So we've talked a little bit too about you winning the IFFGD award in 2013, but what other acknowledgments have you received since winning the IFFGD award in 2013 or even before?
Yeah, I've had a couple of research prizes, all of them always very pleasant to get. So an early one that I got was a national award for GI research, which I actually got just at the end of my PhD. And at that time, in current money is not a lot, but at that time this was like 6,000 euro equivalent. It was a lot of money to win. But then a couple of highlights have been the Janssen Award at the Digestive Disease Week, which existed until I think around 2010. And that was an international award that you could get, which was handed out at a very solemn reception at DDW. I also won the research award for the International Neurogastroenterology and Motility meeting, a very prestigious one, which was handed out every 2 years, and I think I was the fourth or fifth person to win it. And then I also won the United European Gastroenterology Research Award. That is a competitive one throughout the whole field. I think I was the first and unfortunately only functional or motility person to win it, but I won it. I think it's there, 2015, so 2 years after the IFFGD. That is a prestigious one because you are competing with surgeons, hepatologists, IBD people, endoscopists, oncologists. So these are some of the very visible ones that I have won, and all of these are international. So I think that kind of speaks in favor of their weight.
Yeah, significant weight. And it's a testament to all of the impact and the things that you were doing too in the field of GI to advance the field. And it's like what you said at the beginning of this program, where it's nice to be recognized, but that's also just adding another step to really being able to investigate and research these topics even more so. So congratulations to you for all those acknowledgments that you have received.
Thank you, but you know, it takes a couple of things for that. First of all, you need to love what you are doing.
Yeah.
And you know, if you love what you are doing, which I do, then it's not difficult to dedicate the time to it. And then you need to be very lucky on two accounts as well. One is you can do research and have reasonably interesting results. If you're unlucky, you have negative results. If you're very lucky, you find something that resonates, or you publish something that resonates. So you need a level of luck. And then there is a mixture also of luck and kind of controlled luck. You need to be very lucky in the people you run across. And these are at two levels. These are your mentors in the beginning of your career. So I was put into this pathway by Gaston van Trappen and Jeff Janssens. They are retired a long time now, but they put me into this part of the field. These are the ones who said, you know, do what we have done, but try to do a little bit more for the patient. So that put me in the right direction. And then I grew the group and had people come to work with me for PhDs or from some clinical training. And there I've been very lucky. I've had some of the most excellent people working with me, and they really advanced my career. They benefited from it as well, I hope, because they got nice publications. But it made a nice atmosphere and a productive atmosphere. So you depend a lot on who you work for at the beginning and later who comes to work with you. And I've been very fortunate there. So I want to use this video to thank everybody who published with me, because they contributed to where I am now and where the field is as well.
Yeah, for sure. And you touched a little bit too about why you have to love it, right? You have to love exactly what you do. So why do you enjoy, or what do you enjoy the most about being a researcher, and why?
Well, I think loving research is a kind of mindset. So already as a student, I did some student research. This is more organized now at many universities, but this was early days, so most students didn't do that. I went to a lab in the holidays, so that is part of it. I've always had some interest in research, but in our field, which is not the most popular field in medicine and not in GI as well, there are people or there are fields which attract more of the young talents right now. And I think what you can do in our field is there's a lot you can still achieve on your own. In cancer or inflammatory bowel disease, we can still set up our own trial, think of what we want to test, organize it, collect the patients, because there's a lot of patients, collect the data and decide whether it's an addition to the field. And if you look at treatment algorithms, they're rich, there's many steps, but in some of the functional disorders, there's 1 or 2 steps where I can say, you know, this step is in there because of a study I did, and this was not an industry-sponsored trial, it was our own trial. Our field is unique in being able to achieve that. I think this is very rewarding. And some of the people who are not dedicated to these patients say, oh, they're a very tiring group of patients. They can only say it with words because you don't see anything on the endoscopy or on the blood works, and you know, they complain, and they're very tiring. If you can see this as a richness, because every patient is different. And okay, some of the patients are very obstinate in claiming how bad the symptoms are. There's 2 aspects to that, 2 approaches. You could say, this patient is exaggerating, complaining all the time, and the endoscopy was negative. What's the point? Or you can actually believe them, go with them. This is what I do. And then if you manage to get them better, which is not always the case, but even if we follow our patient, we get the majority better. You get a different person. And it actually shows that if you take away the burden of the symptoms and you're successful with it, you find a different person who is much easier to deal with. So some of the, let's say, time demanding or attention demanding approach that the patients present to you and their attitude, it has to do with severity of the symptoms. And if you get them better, you actually see that this becomes a different person. And even there are patients who you cannot help very much. I'm not a wonder doctor or a miracle doctor, so I have a bunch of patients, and I've seen a lot of patients, so many of them, where at the end of the day, you feel you haven't been able to improve them the way you would have wished to. And sometimes you see them back after a long time, and sometimes they are very grateful. And then I have to say, but if I look at your file, I have the feeling that we were not so successful. We didn't manage your symptoms to the extent that I would have loved to. And some of the patients said, yes, but you tried and you took them seriously and you accepted the symptoms. And that already was very important to me. So sometimes reward and making a difference is at a lower level than we would expect. And if you see them back, it's sometimes a patient that you think I didn't do very well there, I didn't succeed, who are still grateful. So I find that also rewarding.
Yeah, it's very rewarding because, and you know too, how symptom burdens can have a significant impact on quality of life for patients living with GI disorders. So, like you said, just really taking in the patient perspective, hearing them, understanding them, and just taking a moment to just take a step back and see what type of approaches can we take just to make just a tad bit better of a quality of life for each one of the patient. And I love that
Definitely.
perspective.
Yes, and I don't believe that anybody just comes to the hospital to waste our time and get attention. I think people come because they have a problem. Going to a clinic is not very pleasant. The investigations we do are fairly unpleasant. So to sometimes very unpleasant or demanding. So if people want to go for it, it means that the symptoms are burdensome enough to put up with all the rest. So I think at the end of the day, it's the patient who determines this is a bad problem or not. And I think as a physician, if you don't believe that, I think you're wrong. You cannot estimate what the burden is to the patient. And I think that should motivate you to try and take away the burden. Okay, and perhaps in some cases you say, I'm not the right person to solve your problem, but at least you should do the effort, try to gauge the symptom, try to measure what is perhaps the impact, try to estimate what is behind it. And if you cannot solve it yourself, at least make sure that somebody else makes the effort, not send them away and says, I think it's nothing. I mean, this is denial, which is very disadvantageous and doesn't help anybody. And I think if patients come to a clinic, and sometimes with a long waiting list before they can come, it means it's a serious problem. It's not a frivolity or a waste of time. Nobody does that.
Yeah, very significant message there. And thank you so much for just even bringing that to the forefront of this conversation, because that is very important for the patient population to be understood and to raise awareness about these GI conditions. So in speaking about this, what do you see as being some gap needs still in the area of research? And how do you foresee some of the research coming from your lab to fulfill some of these gap needs?
Well, I think there's a couple of challenges. I, I think the input from industry in terms of innovation for a long time has been limited. Our field has suffered a stigma, and I think this is a little bit better in the US. Is still very problematic in Europe with the idea that this is a very difficult condition to develop new treatments for, be them pharmacological, which is what many companies still do, or other types of intervention. And thinking it is too difficult, cannot be done, it's too vague, and even if you have something, it's not even possible to get a decent return on investment. So I think our field is suffering from that. And it had a couple of implications. One is if we got an effort for a drug, it was kind of a Me Too drug. We've been there, that worked, let's try it again. And because we know that works. Focusing on the same conditions, there's many functional GI disorders. People have homed in on IBS and close to it chronic constipation. The rest has hardly been addressed, and there's no track, and nobody dares to step into the track. We don't have drugs for globus, we don't have drugs for functional heartburn, we don't have treatments for functional dyspepsia which are established to work, we don't have working treatments for gastroparesis. It's like you cannot go there, cannot be done, it's too difficult, nobody has seen any success, let's not try. Part of this has then been solved by the non-pharmaceutical industry, by, let's say, phytotherapy, some of the alternative therapies that were brought to market as a food supplement. Then you don't have to go through the loop of proving efficacy. Unfortunately, these are smaller companies, perhaps with lesser financial abilities, and then you get research which is incomplete and doesn't fill the picture. I have nothing against phytotherapy. I use herbal treatments because I think some of them have some efficacy. But for a drug, you need two 12-week trials and a 1-year placebo-controlled and a 1-year extension trial. This is not done for these perhaps less developed therapies, herbal therapies, nutritional supplements. Some of them might be working. The evidence is lagging behind, and that actually prevents them from being picked up in management algorithms. I think if some of them were tested, we would probably see they probably work as good. We see some evidence from the dietary interventions that has been done by clinicians, and you can get a level of evidence. So that needs to be addressed. So that is all the bad news. The good news is that we are focusing on some mechanisms, neural mechanisms, low-grade inflammatory mechanisms, long time already, research is in that field, which are being tapped into for other conditions. And suddenly we see spillovers that you can use some of these for proof of concept, showing efficacy in our field. Now, these are usually very expensive drugs for severe, perhaps life-threatening disorders. I don't think the hurdle will be lowered to use these drugs at that cost for our conditions, but it opens a perspective for finding other ways of tapping into these pathways. I expect that this will be happening in the next 5 years, and that perhaps this will be then tapped into with easier to use approaches, but I think we'll see an enrichment. For now, we'll have to do with some of the older principles. I hope that at some point in Europe, pharmaceutical industry becomes more active. I would like to increase the level of evidence behind the food supplement and herbal type of approaches. You know, herbs work on receptors at the end of the day. They may be efficacious as well. I would like to see a little bit more evidence. And then I hope that the pharmaceutical industry or the biological industry who make specific molecules that seem to be working for some of our patients, that this path is then further established to use equivalents or maybe less expensive approaches to achieve the same for some of our patients. And I think this is going to happen. So I think 5 years from now, the field will have evolved, will be better in understanding disease, and probably a little bit better at managing them as well.
Yeah, and that's the exciting part. It's just there's hope for the future, and we all know that definitely raising awareness and just bringing attention to the symptom burdens and the quality of life of patients suffering from really all chronic illnesses, especially GI disorders. That's just one way of really getting some federal investment in this area so that we can broaden the research topics and broaden our understanding about the GI conditions for sure. So we are really excited about all of the research that's coming from your lab. And like you said, we're excited for 5 to 10 years from now to really see what else we understand about these conditions.
Yeah, there's one thing that I would like to point out as a development which may really advance the field. At some point I've said I think these are heterogeneous groups of patients. We have treatments that are working, we have newly emerging treatments that may work for subgroups. We need to identify the subgroups and find a way to identify them. The only way is if internationally researchers who see a lot of patients try to start to collect the data in a similar way, pool them, make big databases looking at characteristics in terms of symptoms, in terms of demographics, genetics, phenotype, and then follow them through treatment and see what helps for which patient. And there's 2 big things that are happening. One is there is a Horizon 2020, so that's a European level funding effort, which is called Discovery, which is going to collect patients with IBS and comorbidities, phenotype them very carefully, follow them over time. This will be a huge cohort in many different European countries, collected in a systematic, similar way in Sweden, Belgium, Norway, Spain, and so on, Italy, the Netherlands. So this is a well-consorted effort which will generate a database. And the second one is the Rome Foundation Research Institute. This is a research organization created as a spin-off of Rome to address some of the questions that are not being addressed. So every 10 years, Rome puts out new criteria and a review of the literature. And it always lists areas requiring further research. And unfortunately, I've been in the field long enough to see the areas of unfulfilled research. They're the same ones coming back. Somebody has to do it. We have to do it ourselves. And this is what Rome was also doing, bringing together groups of investigators which will collect, now not on a European level, but on a global level, patient characteristics, patients' data, outcomes, biological samples, to help advance the field by creating magnitude of data sets. And this is the secret, I think, that will help the field forward. And if a company says, we think we have a new pathway to address some of these patients, organizations like that will be able to come forward and say, we have a database. You can actually see where this pathway or target is activated. We have X hundreds of data sets, X hundreds of biological samples. We can do the analysis and maybe we find a phenotype there. This is happening. It will take a couple of years. This is not an overnight event, but this is starting to happen.
Yeah, and it's very exciting to hear that there is hope and there is light at the end of the tunnel, and that there's things out there being done, to really advance the field. So that's very exciting just to kind of hear about some of the things that are in works and coming around for patients and for the general public to better understand these GI conditions. So I just want to say thank you to everyone who has tuned in.
It was a pleasure.
Yes, thank you so much. And thank you everyone who has tuned into IFFGD's Research Award Winner Series, Where Are They Now? I mean, it's been a pleasure to catch up with Dr. Tack and to really just understand his journey from winning the IFFGD award in 2013 to where you are today. And it has been a pleasure of speaking with you today. So thank you.
Likewise, the pleasure was mine.